Good morning. Today's topic is emergency hysterectomies and their follow-up. #learn simply. The emergency hysterectomies are just like the way to get started is to quit talking and begin doing. Actually, in last 30 years of my practice, I have found out that the change of the emergency hysterectomies, the indications have changed from uterine atony to the abnormal placentation, and this very, very important subject. The emergency hysterectomy is a surgical removal of the uterus and usually performed for the uncontrollable maternal hemorrhage when all other conservative managements have failed. It's basically the life-saving procedure and it is very, very important. There is a hysterectomy about the emergency obstetric hysterectomy. It is proposed in 1768 by Joseph Cavallini in animal experiments. The first documentation of Caesarian hysterectomy was performed SUBTOTAL in 1869, and in 1876, Udarino performed the first Caesarian hysterectomy in which both the mother and baby survived. The incidence has changed in last few years, but it is 0.004 to 1.5% of all 1,000 deliveries, the TLAM says. 0.24 to 8.7 per 1,000 deliveries in the North American Journal 2011, but now it is 30 per 100,000 following the vaginal deliveries and 270 per 100,000 following the Caesarean section. So incidence, though it's not increasing, but the indication has definitely changed. Doing Caesarean hysterectomy as I am being called for many places for doing hysterectomy, in my heart of heart, the hardcore vaginal surgeon I always feel why we want to remove the uterus, because it's a really heartbreaking thing for the doctor also and for everyone to have the removal of the uterus in young fertile females for some reasons. So these are the risk factors. Normally nowadays, the indication is previous cesarean section, abnormal placentation, including all previas like archreta, accreta, everything. Multiple gestation is another troublesome thing. Grand multipara, which is rare nowadays, but it is still there. Fetal macrosomia is again with the increase. India is another diabetic capital of the world. So the mothers are also diabetic and chances of fetal macrosomia is also increasing in our country. Sometimes there is a previous history of PPH is also there, coagulopathies and chorioamnitis. Coagulopathy is the one field in which the chances of hysterectomy is also less, emergency obstetric hysterectomy, because there are so many things are coming up to treat them, and same with the uterine atony. So we can classify the EOH, like first is the circumstantial, that's emergency, sometimes indicated and elected. Extent, we can do it supracervical, total or radical. And clinical context, this is a planned Caesarean birth and emergency Caesarean birth and postpartum. In emergency cases, these are the things which are make the indication: uterine hemorrhage, 26%, placental problems, previa, abruptio, accreta, 11%, uterine rupture, 7%, postpartum atony, again, it should be differentiated with the uterine hemorrhage, that's a 5%, extension of Caesarean section scar or the incision to the uterine vessels, 3%, infection, chorioamnitis and sepsis may be one of the reasons for this. But nowadays, with the incidents are more and more previous sections, patients are coming with abnormal placentation. It's the most common indication. Incidence is increasing due to the increased rate of C-section. Accreta, increta, percreta are becoming common. But we need a 3 PPP procedure for this. Number 1, a preoperative location of the placenta and delivery of the fetus by the incision above and upper border of the placenta. Number 2P is pelvic devascularization by inflating radiologically pre-placed occlusion balloons in both internal iliac arteries. And third is a placental non-separation with a myometrial excision and reconstruction of the uterine wall. So triple procedures, abnormal presentation, prevention of the surgery is very, very important. Atony, this was the number 1 cause for the obstetric hysterectomies previously, and atonic postpartum hemorrhage is a constant bugbear of the obstetricians. Failure of the sequence of all conservative measures. there is a relationship between the blood loss and the duration of the time that passes prior to the decision for hysterectomy, and the possibility of the hysterectomy getting complicated. So uterine atony is the biggest thing. And uterine atony is reduced due to the liberal use of pharmacological treatments. And previously the uterine atony, which we call is a tissue trauma and thrombosis, and we are able to manage it very well nowadays. So the decision making, the timing is critical for the emergency obstetric hysterectomy, and hysterectomy should not be performed too early or too late. Most important point, a sequence of conservative measures should be attempted before restoring the radical surgical procedure. Really, it's a heart-breaking things that we should do all the conservative measures before attempting any surgical procedure. Indecisiveness, delay therapy results in the fatal hemorrhage. And another, there is a very, very thin line between the decision and indecisiveness. So when to take a decision, what is the decision, and what right time of doing the decision is very, very important. And increased duration of time increases the likelihood that the hysterectomy will be. If we will delay into the hysterectomy, there can be a seriously complicated by coagulopathy, there can be a hypovolemia, there can be a tissue hypoxia, hypothermia and acidosis, and which compromise the patient's status. So the decision making is very, very critical. ACOG recommends that if hysterectomy is performed for uterine atony, there should be a documentation of first attempting all other therapies. So we should not do any surgery unnecessarily, not needed things. We should attempt all those things. In most of the cases, suspected placenta accreta, however, the hysterectomy should be the primary management, especially when the woman does not desire future fertility. So other very important. Now we need a pre-planning. We should not do the surgery immediately, and what pre-planning includes. Number one is the proper consent, and explain the possibility of the high-risk patients. Consent should be very, very wide, very, very vivid, very, very important. So the consent is very, very important. Adequate blood arrangement, FFP arrangements, all the blood products arrangement. Prophylactic antibiotics, arranged for general anesthesia. This is the subject when we need a multidisciplinary team consist of obstetrician, obstetric anesthetist, urologist, vascular surgeons, and interventional radiologist. And then appropriate instrumentation should be available. So there is a big list of what are the instruments we should have. So we can do, and the patient's preparation, how to tie the patient, how to make the patient's lie is very, very important. And patient stabilization is also important by giving blood products, uterogenic agents, multiple large bore IV lines, arterial line, warming devices, rapid blood infuser, and incubation equipments. Now, this is a care bundle which we need for the obstetric hysterectomy. Number one is a consultant obstetrician, planned and directly supervising the delivery. Consultant anesthetist, planned and directly supervising the anesthetic at delivery. Blood and blood products available. Multidisciplinary involved in pre-operative planning. Then the discussion and the consent. There was a discussion that the discussion and consent should be first, or the consultant obstetrician and the remaining things should be first. If we'll have a team, then the discussion and consent has got the role. That includes the possible intervention such as hysterectomy, leaving the placenta in a place, cell lavage, or interventional radiology. All this discussion and consent should be there. And last and most important is local availability of the critical care bed. While discussing or taking the consent, we should be responsible for shifting the patient to the critical care bed as needed, and that should be a local availability. It's not available at your own places. So the take help from the urologist in cases of Burkitta, posterior bladder wall partial cystectomy may be required. An interventional radiologist in the cases of suspected pre-op placement of the hypogastric artery balloons, bilaterally decrease the blood loss and avoiding the need of embolization. So, but whatever the things are there, if you have decided the surgery, but the most important there is for emergency obstetric hysterectomy, we have many surgical pitfalls. Number one, normal pelvic anatomy might be distorted. Vascular pedicles are thicker and more edematous. The vascular pedicles should be doubly clamped to avoid the slippage of the ligature. Small pedicles should be secured and not tied when they are correct anatomical plane without torsion, twisting of the pedicles, because slipping of the pedicles and the getting the not moved out of from this pedicle are very common with all this thing. Another surgical pitfall is bladder might be adherent to the lower segments, especially in the previous Caesarian section. Presence of uterine tears or the extension of the uterine angles might increase the risk of ureteric injuries during the placement of sutures, and unintended oophorectomy due to the shortening of the ovarian pedicle. So there are chances of one or the other ovary getting removed, but we should give the consent, we should take the consent, we should discuss all those things. Another surgical pitfall is there is a difficulty in identifying the cervix, especially the hysterectomy following the C-section done at the full dilatation. The tissues might be very friable and there can be added difficulties. Great care is necessary to avoid the injury of the organ or adherent, uterus, bladder, adnexa, and abdominal wall. Surgical pitfalls are again, it's a really education. The surgeon must be prepared to recognize and repair the injuries of the urinary tract. Hematomas of the broad ligament and the neighboring structures make the visualization difficult, and anatomic relation. Careful exposure, skilled assistance, and attention to the hemostasis are primary importance. Need of an experienced senior obstetrician, second opinion from the another experienced one is important. Surgery should not be delayed. Less definitive procedures with the surgeon has little experience should not be attempted. So another pitfall. Procedure is simple. Incision midline vertical or fenestrial. Vertical midline is preferred. Emergency situation, hypogastric artery is and ligation is anticipated. Enter by the earliest method. Delivery of the best accomplished classical low vertical incision can be made and hemostatic using the towel clip or single learning sutures. Exposure is best obtained by the traction of the uterus along with the retractors. Steps are similar to the abdominal hysterectomy with some precautions. So it's not tough. Just doing a simple hysterectomy we do, but mind it, the pedicles are large, they are edematous, more vascular. So securing all those things are very important. First the round ligament, then the tubo-ovarian, then go to the uterine, separating the bladder and do it. But if the cervix is fully effaced, palpating the upper vagina, pinching to palpate the cervix and hooking the finger between the cervical rim and the vaginal wall through the Caesarian incision. So this is the way we should do it, and we can proceed towards the uterosacrals and the mecanthrops, and we can deliver it out. Wall repair is each lateral virtual fornix is secured with the cardinal or the uterosacral ligaments. Achieve hemostasis by running the lock switch of 1.0 place to the mucosa and endopelvic fascia. Some prefer to close the vagina using the finger of 8 chromic catgut. Indwelling catheter drain and suction drain is required. And the vault closure is similar, that which we used to do in a simple hysterectomy. But sometimes we do the subtotal hysterectomy. Why we do the subtotal hysterectomy? In a stable patients, keep pedicles small, ensure they are carefully and doubly ligated. Engorge the edematous tissue and exist following the delivery can cause vessel tight within the large pedicles and they slip or retract. But in unstable patients, quick clamping, cutting until the bleeding is controlled and uterus is removed. Pedicles are tied off after the suturing, ensuring the hemostasis. Total hysterectomy is the operation of choice in cases of placenta previa. But the subtotal hysterectomy for sometimes unstable patient, when the removal of the cervix is not essential for hemostasis, bleeding is due to the uterine atom. But the problem, the advantage is less operating time, reducing hospitalization, reduced risk of bladder and ureteral injuries, and disadvantage is potential risk of malignancy in the cervical stump, need for regular cytology, and bleeding or discharge associated with the residual cervical stump. So this is the problem. Now the post-operatively record the indication of the surgery. Very important. Have discussion with the patient when she recovers, especially the primary parents. Bladder drainage, 7 to 8 days, bladder injury. Tackle postnatal symptoms that require counseling. So all these are important. The complications are febrile morbidity, blood transfusion, coagulopathy, ICU requirement, mechanical ventilation, urologic injuries, and last and most important is sometimes reoperation, 2 to 4% intra-abdominal hemorrhage and other organs damage. So these are the complications which we face after the emergency obstetric hysterectomy. But the important point is all the morbidity of the patient is not because of the surgery, but because what she has suffered earlier and what was the indication of the hysterectomy is there. So incidental bladder injury can be there, gush a clear fluid in the operating fluid, repair at the primary surgery preferred, lowers the risk of post-vaginal, post-op VVF, vaginal fistula. After confirmation of the urethral patency, bladder closure done by 2 to 3 layers, none in the closure, and continuous bladder drainage in a post-op period. Oophorectomy is a topic of discussion because they are young, they are fertile. Should we do or we should not do? Due to inadvertent clamping of the ovarian ligament at times to stop bleeding from the infundopelvic vessels, and 5% periatim hysterectomies, one adnexa was removed to stop bleeding. So this is another. Now these are the changing trends which I am finding in last few years, because I am being called for doing the Caesarian hysterectomy at my place from various calls and various things. But now the trends are changing, and I feel really, really happy that not being called for emergency obstetric hysterectomy, because it's not good for the young females. Number one, because of the increase in cesarean section rate, there is a risk of placenta accreta becoming commoner. Hemorrhage ATONY has decreased due to the increased success in the treatment of iatrogenic agents, prostaglandins, embolization, uterine catheters, and surgical procedures. Reduction in elective procedures, and there is a downward trend in the incidence of uterine rupture with modern obstetrics and reduced parity. Now the summary is very, very important. A dilemma where the decision regarding the emergency obstetric hysterectomy is a last resort to save the life of the mother. Number two, can be made rarer by good antenatal care, active management of third stage of labor, early recognition of the complications, and performance of the C-section at the right time. Triple P procedure we should learn, because this is the thing which we need in future. Fourth thing is a sequence of conservative measures to control uterine hemorrhage should be attempted swiftly before it instituted. Fifth point is indecisiveness delay therapy results in a possible fatal excessive hemorrhage. So the decision is very, very critical. Time of decision is also very critical. Hysterectomy will be seriously complicated by coagulopathy, hypovolemia, tissue hypoxia, hypothermia, acidosis, and further compromise the status of the patient. And timing is critical to an outcome of the hysterectomy. Should not be performed too early or sometimes too late. Too early is not bad, but why we should remove the uterus of the young fertile patients is a question. So we should be believing that. Now these are the take-home messages. Emergency obstetric hysterectomy is a necessary evil in obstetrics, curtails the future childbearing potential of the woman, saves the life of the mother. Morbidity is attributable to its indication and underlying disorders rather than to procedure itself. Post-graduation training and the teaching the skill to prove life-saving is a tough question and should be answered. And rising rates of cesarean section, multiple gestation, ART pregnancies are bound to increase the incidence of emergency obstetric hysterectomy in future. So be careful about it. Thank you so much for the patient listening. I'm really, really thankful to all of you for listening this topic of emergency obstetric hysterectomy. It's very close to my heart as being a hysterectomy specialist, being called, but doing an emergency obstetric hysterectomy, I don't enjoy the thing. So thank you so much for patient listening.